All right, good afternoon and welcome everyone. We hope that you are doing well. Thank you for joining us today for our session that's titled Ready, Set, Go, Getting Restarted with TAKEheart. My name is Cynthia Klein. I am from Apt Associates and I serve as the project director for the TAKEheart initiative. I cannot tell you how happy I am, and I know our full team is today, to be restarting TAKEheart training modules with the combined module 1 and 2. We have a great lineup of speakers today, including Kim Newland and also Dr. Hisham Scally. So we've got a great session for you today. On the next slide. Before we get started, I'd like to pause and just introduce Dina Moss from the Agency for Healthcare Research and Quality, who wanted to say a few words. Dina?
Thanks, Cynthia. I am absolutely delighted to be here. And on behalf of the Agency for Healthcare Research and Quality, which is sponsoring this initiative, I want to thank everyone, all of you, for your participation, especially in the face of the extraordinary hurdles you've all faced over the past year. We at ARC are just incredibly gratified by the collective enthusiasm that you've shown as you're joining your peers from around the country and work to increase patient participation in your life-changing and life-saving cardiac rehab programs. And as you can see from the map, we have quite an impressive geographic breadth to the TAKEheart partner hospitals who are with us here today. I think we now have 57, so bravo to all of you for stepping up. I also want to thank our partners from Million Hearts and CDC and our extraordinary project team led by Apt Associates, who've worked tirelessly to build the TAKEheart training program, and they're also going to be the team who will be supporting you in your efforts over the next month. So thanks to everybody who's had a role in this. My TAKEheart co-lead, Michael Harrison, and I feel just incredibly fortunate to be a part of this really, really important effort. So thank you for the opportunity to be here, and back to you, Cynthia.
Great, thank you, Dina, appreciate it. And appreciate again everyone joining us. Dina's right, we've got a great group of hospitals to be taking this journey with us, and again, are just super excited to get started. On the next slide, Dina put it very well. We know and appreciate that a whole lot has happened since we last met. So as a reminder, TAKEheart launched in January of 2020 with the delivery of the first 2 training modules. Some of you may have already taken a couple of these training modules, the first 2 presentations last year, but as we are moving to restart, and because time has passed and we have both new and returning hospitals joining us, we have decided to combine today's presentation into what was originally those modules 1 and 2. So we'd like to use this combined presentation to remind you about the basics of the program and also generate hopefully some excitement for what's to come. Just as a programming note, these training modules will be made available on the TAKEheart website, and here's a reminder of the link to the website as well. It'll take a couple of weeks for us to be able to post those materials, but they will be available in the future. All right, next slide. So this is really just as we get into the content of today, just a reminder that it's really important to know that all of the training, the educational resources, and the technical assistance that's offered by TAKEheart are really designed to apply the evidence-based strategies from the Million Hearts and AACVPR cardiac rehabilitation change package. So as many of you know, Million Hearts 2022 is a national initiative to prevent 1 million heart attacks and strokes within 5 years. It's a pretty audacious goal. It focuses on implementing a small set of evidence-based priorities and targets that can improve cardiovascular health for all. The initiative seeks to keep people healthy, to optimize care, and to improve outcomes for priority populations. And one of the goals that's set within Million Hearts was to create a roadmap to increase the use of cardiac rehabilitation to 70% of eligible patients. So this cardiac rehab change package, we call it the CRCP, really serves as this roadmap of how to get there. And you will hear it referenced several times today and in the future because it really does serve as the guide for all of our training modules. Let's go one more slide. So the CRCP includes evidence-based strategies. It includes case studies, 100+ tools and resources, and they come from a number of different sources. They come from 18 states, 22 institutions. There's 36 cardiac rehab professionals and researchers, just like yourselves, that contributed to it. And it's all aimed towards increasing participation in cardiac rehabilitation with eligible patients. So as part of TAKEheart and using the CRCP developed by Million Hearts and AACBPR, the purpose of these training modules is to support partner hospitals to implement a quality improvement program to adopt 2 evidence-based strategies for increasing referral and enrollment. And these are automatic referral of patients and care coordination. All right, as we move forward in our training, I'd like to pass you off to Steve Hines. Steve?
All right, thanks very much, and good afternoon to everyone. We are delighted that you're here this afternoon, and we just wanted to review the 2 major training supports that we're offering to all of the participants. First, there are the training curriculum modules like the one today, and these monthly training sessions, with the exception of this December. We'll feature subject matter experts that will discuss the content that you need to understand in order to be able to effectively implement automatic referral and care coordination. So, and to make these events as interactive as possible, we encourage you to use the chat function to participate in the polling questions and to do to just ask the questions that occur to you as you're listening to our expert presenters. Then, after each one of these training modules, there will be a partner hospital peer action group. Your hospital has been assigned to a peer action group along with all of the others. We've tried to group those so that you're in a peer action group that has hospitals that you can learn from and hospitals that you can share with that can learn from you. So we want those to be forums where everyone shares, everyone supports, and that's how we can help you as you work to go through the process that's necessary in order to be successful in TAKEheart. So to look at the next slide, we want you to be aware of the training curriculum and the sequence that we're taking you through. First, we lay some foundation. We're doing some of that today, talking about aims and why TAKEheart is important. Then we want you to understand workflow processes, because before you can automate anything like the referral process, you need to understand and make sure that the process is going to be a workable one. And the same is true for care coordination. Once we've done that, we also want to spend a module focused on data. And we really encourage you to be looking at your data already, because if you don't have the data in place, you're not going to be able to either program your EMR in order to automate the referrals, or to understand the progress that you're making and where you need to continue to improve to make sure that you're supporting all of your eligible patients. So those 4 modules, as well as the last model that's going to discuss virtual or hybrid cardiac rehab, those are foundational activities. And then those are complemented by modules that focus on the core activities of automatic referral, so that you can understand how to do it and then how to refine it. I doubt it will come as a surprise that your first efforts are going to need some enhancements to make them work as well as you want them to. And then the same is true for care coordination. We want you to be able to coordinate the care for all of your patients. And really, this is not a matter of solving a problem through automatic referral or care coordination. In order to really maximize the impact of your program, you need to accomplish both of those. And we're delighted that your participation in TAKEheart reflects your awareness that both of those are very important. All right, we mentioned the chat function, and on the next slide, we just want to remind you of how the chat function works. You can open the chat box if you haven't already. And then we encourage you to set who you're sending your messages to everyone. All attendees might seem right, but then the panelists can't see it. And if you put panelists in there, then the audience can't see it. If you pick everyone, then everyone can see it. And we want to encourage you to be looking at the chat comments, responding to them based on your own experiences, as well as seeing the comments from others. So that's the chunk chat function. If you want to take a second now, say hello to other people, just get a little bit of experience using that, we encourage you to do that. It's pretty straightforward, and we pay attention to those comments, and our presenters today will try to respond to as many of the chat comments as they can. Then in addition to that, you'll see that there's a slide related to the polling function. We like to ask questions during these events. It helps us to understand where you're at. It helps us to plan for the future. It helps us to kind of ground what the presenters are saying in the experiences of the audience. So we'll get to a couple of polling questions in just a minute, but they'll give you another opportunity to interact with the panelists on today's and on future events. So use the polling function. It's pretty straightforward. And if you participated in any of the TAKEheart affinity groups up to this point, you already should be familiar with that. We have arranged for CEU credits to be available for this through ABQARP. And if you did not apply for CEUs for Module 1 and 2 last year, then you can apply for those CEUs for the training module today. For subsequent trainings, modules 3 through 10, since we didn't offer those in the past, anyone can apply for and get CEU credits for that. The instructions on how to claim your CEUs for this training will be provided at the conclusion of the program. You need to participate in the entire training in order to gain those CEUs. So we encourage you to do that if it has value to you, and we are delighted that ABQARP has agreed to support this project in this way. So that is the CEU credits. As far as today, we like to be clear about what we'd like you to accomplish today. So if you look at these learning goals, we want you to understand TAKEheart and how it can help close the gap between evidence and practice to increase patient participation in cardiac rehabilitation. And we want to stress that it's not just increasing the number of people that enroll that finish. That's important. But it's also about increasing the number of eligible people that do enroll and do participate beyond the current numbers that you have. Secondly, we want to make you to be able to make the case to your leadership for supporting TAKEheart and taking active steps to increase cardiac rehab participation. You're going to need all the help you can get, and that certainly includes your leadership when it comes to implementing automatic referral and enhancing care coordination. We do want you to understand the role of the cardiac rehab TAKEheart champion. That's a very important role. We hope that most of the champions are on this call today. And then we want you to understand the other sorts of team members that you're going to need. This is not a one-person project that any one person can do. It's going to take a variety of skill sets and backgrounds and knowledge of your processes to succeed. So we want to make sure that you have the right team and then that you've set the right goal. And so we'll spend some time talking through the importance of choosing an effective aim statement so that everyone involved in your project, everyone that wants to know what you're spending your time on when you're working on the project, so that they understand in very clear terms what you're trying to accomplish, why it matters, and and how quickly you're aspiring to achieve the aims that you set. So those are the goals for today's session. I'm very delighted as we look at this next slide for two reasons. One is because we have fabulous presenters. We're delighted to introduce Dr. Hisham Scali, who's the TAKEheart principal investigator and the associate director of cardiac rehabilitation at the Brigham and Women's Hospital in the Division of Cardiovascular Medicine. Dr. Scally has been a terrific colleague and supporter of the project, and we're delighted to have him on. And then we have Kim Newland, a nurse who's the director of nursing clinical operations at Sutter Roseville Medical Center. And she's the immediate past president of the Preventive Cardiovascular Nurse Association's board of directors. She's been involved in a leadership position for over 6 years and has seen substantial growth in her programs over that time. And then both Hisham and Kim really understand the importance of process improvement because that's essentially what TAKEheart is about. None of you would say that you don't coordinate any patient care or that you don't do referrals, but I think all of you would say that you've got opportunities to do both of those things better. And we're delighted that Hisham and Kim can help start the process of guiding you through that. So the second reason I'm delighted we've gotten to this slide is because that means that I can turn it over to Hisham, and he and Kim will take it from here. As a reminder, anytime you have a question or a thought or an observation, enter it in the chat. We'd like to see that, and we'll respond to as many of those comments as we can. So Hisham, I'll turn it over to you.
Thank you, Steve. And as the slide says, let's get started. I'm extremely excited and delighted, like everyone said before me, to get back on this TAKEheart initiative. And we'll get into the details of what it is, what it means, and what it is expected from all of us. It is a tremendous pleasure to talk to all of you, and I really welcome you to the real start of TAKEheart. So as we're starting, I'd like your participation first in answering a couple of questions. The first polling question that you'll see here is what best describes your feelings about the TAKEheart project? And you have 4 options there. A is ready to go, B, excited but nervous, C, neutral, and D, worried. And you have about 40 seconds or so to go to answer that. All right, can you see the answers? Excellent. So we have about 28 people who answered so far, and 40%, 23 out of 57 who are ready to go. And actually, no, and another 40% were excited but nervous, and 5 who are neutral. So 90% of participation rate so far. That's really very encouraging. Those who are nervous, I hope this will ease it out for you. And those who are ready to go, let's get going. The next slide, please. So as you resume TAKEheart, what do you anticipate being your biggest challenge? And the answers are there in the polling box. So A, finding time, B, getting and maintaining leadership support, C, limited capacity, and D, limited resources. So I think the majority or the largest number has been people finding the time, and then the next number is limited resources. So hopefully with TAKEheart, we can't expand time, but we can help you navigate the challenges that you might encounter, and see how you can make the best use of your time and how you can garner the support that you need from around you and use your resources to the best of your abilities. Let's go to the next slide, please. So what is TAKEheart? TAKEheart is an initiative funded and hosted by the Agency for Healthcare Research and Quality, ARC, as we call it affectionately. And it offers a set of selected hospitals, our partner hospitals, free virtual training and support and technical assistance in how to implement 2 evidence-based quality improvement initiatives. Those are automatic referral with care coordination. And the major goal for this is to increase use of cardiac rehabilitation participation and utilization. And what does automatic referral mean? Next slide, please. So this is an order that's based entirely out of the electronic medical record, where the order to refer a patient to cardiac rehab is automatically generated in the chart and is designed directly as an opt-out option. It is designed specifically for patients with the eligible diagnoses, and we'll go over these later on. But it is an opt-out option, meaning that there has to be an active action, an active decision by the user of the EMR to opt out of this order. And accordingly, this order will go into the queue of the relevant providers and should be taken after that. This will allow an efficient and systematic referral to outpatient cardiac rehab for all patients being discharged from the hospital. And so this should lead to an increase in the referrals. Next slide, please. This works best when it is combined with what we call care coordination support. And this can be in a variety of forms and shapes. So it can be dedicated staff that does just this, or someone else in-house taking on this role of ensuring that every patient that has an eligible diagnosis and has an adequate order for cardiac rehab referral is actually, the loop is actually closed so that the participation is actually implemented. This role will require appropriate training, and it will lead to the meeting with the patient and contacting the patients and the rehab facility to coordinate the referral. This will also increase their enrollment, and in studies, it has been shown that this step also increases adherence and an earlier enrollment in cardiac rehab. Next slide, please. And no, this is not very new data. In the 2011 study by Dr. Sherry Grace out of Canada, showed that the combination of implementing both automatic referral to cardiac rehab and with care coordination increased participation to 86% in patients randomized to this combined strategy. The control group only had a participation of 32%. So you can see that with these two initiative, these two actions of automatic referral and care coordination, you'd increase referral, you'd increase enrollment, and hopefully increase adherence, which would eventually lead to improved cardiac health, which is exactly what we would like to achieve for all our patients. And so, there is overwhelming evidence that cardiac rehab has led to significant, statistically and clinically significant improvement in outcomes, whether those are mortality or morbidity outcomes in patients with myocardial infarctions, coronary artery bypass surgery, percutaneous coronary intervention and revascularization, or patients with angina. There's another list of diagnoses which make patients eligible for cardiac rehab and where there's data of improvements in their quality of life, mortality and morbidity. But really, cardiac rehab promotes better quality management and limits avoidable adverse events. It also reduces and limits emergency room visits, as well as rehospitalization in the long term. So overall, CR, there has been a lot of cost effectiveness analysis study also that showed that CR is a relatively low cost intervention compared to inpatient treatment for acute cardiac conditions. And it provides a high return on investment given the impact of its benefit. Unfortunately, there remains a big gap in cardiac rehab utilization. In the most recent study that was published a couple of years ago by Matt Ritchie out of Medicare beneficiaries analysis, it showed that only about 1 in 4 patients eligible for cardiac rehab has actually participated. And you can continue with this rule, 1 in 4, 1 in 5. Only 1 in 4 has participated. Only 1 in 4 actually participated within 21 days. And of those who participated overall, only 1 in 4 completed 36 or more sessions. And so the purpose of TAKEheart is to close the gap between what we know the established evidence for cardiac rehab benefits and the low utilization and low participation rates that we observe in everyday practice. So this infographic here is included in your training material, as well as actually all the data that I have mentioned before and citations and references for what I have mentioned before. But this one-page document provides information and references for you, for the hospitals, but also for you, but also for the leadership and at your hospital administrative settings, so you can spread the message and actually help garner support to the implementation of the two initiatives that we have in TAKEheart, which is automatic referral and care with care coordination. And with that, I'd like to turn it now to Kim Newland. As Steve mentioned, Kim is a leader in cardiac rehab and in preventive cardiology. She's also a practicing provider. She's not only in administrative and research, but she also sees patients and makes sure that all these things are happening. So Kim, thank you for joining us and for being with us and supporting TAKEheart. And I'll leave it to you now.
Thank you for the great introduction, and it's wonderful to be back after a year. We're going to actually start with a video, and we'll advance to the slide, and then I'll take it over from there.
Steve is going to share his perspectives initially on how he decided to attend cardiac rehab.
Hello
Steve,
there.
take it away.
Hi there, thank you. I was 52 years old and told that I was going to have a triple bypass in December of 2019. It was kind of a shocker for me, and after going through the entire process, I was meeting with my cardiologist, who related that a system was in place at the Sutter system that I could use that would help me in my rehabilitation and to help me get past the hurdles of learning what's necessary to move on with life. And that was kind of cryptic to me, but it became very clear when I went to Sutter Medical Center and was able to join the class for cardiac rehab.
That's great. So when you think about your experience with cardiac rehab, what are 2 to 3 benefits that you think you receive from cardiac rehab?
A lot of it was helping alleviate the fear I had of what was next. The thing that sticks out most in my mind is when it first started out, how slow we started off aerobically. And I was probably 10 to 15 years younger than just about everybody in the class. And everyone had a great attitude. They worked their butts off every day. And I was wondering why I couldn't do that. And then I realized that with the monitoring and the processes that were in place, we built up our endurance, and we worked hard every day to get better for the next day. And the thing that made me feel better throughout this process was the fact that I was being monitored the entire time, that my blood sugars, being a type 2 diabetic, were monitored from the beginning until all the way to the end of the process, and that there was always somebody there to look after me if I was to fall. And I think that made me feel a lot better, because that was part of my insecurity. So being able to be monitored and to be looked after, so to speak, by these angels that were there was the best thing ever.
When you look back on the referral and the enrollment process, can you think of 2 or 3 factors that cardiac rehab program should keep in mind from the patient perspective?
Not knowing what the class was about at first, from the doctor perspective, from telling me what I was going to be doing, was a little hard to understand for somebody who's always in control. When I first met with the staff at Sutter Roseville, they put my mind at ease. They showed me what we were going to be doing, how to prepare for it, how to eat prior to the exercise that I was going to be doing on that particular day, so I didn't put myself in a risky situation. Going into the class, I don't think that they could do much better than they already did. The folks there were professional. They showed me what they would be doing as far as the monitoring process, and it prepared me for what I was going to be doing from start to finish in the training. All I can say is that the support system they've given me by people that I've met through the class has helped me day to day since the training. If I could stay in the training, I probably would. I would do 2 to 3 days a week just to keep me on track. But the knowledge that they've given me and the way they helped provide not only their support as far as what I should be doing next, but also putting it on paper for me. So if I'm zoning out like I'm apt to do occasionally, that I can refer to my notes. And finally, they also provided me with a complete feedback of my journey from day 1 through day 36. So that was huge, because when I went back to work for the agency that I work for, it reassured them that I was once again the person I was, if not better, and allowed me to get back to work with them having confidence in me and me having confidence in the fact that I would be there and safe, because it can be sometimes I have physical work that I have to do.
Well, thank you, Stephen, so much for sharing your insights with us today. Very appreciated.
Thank you very much for letting me.
So I'm super proud that that's actually one of our patients who was willing to do the interview, and I'm looking forward to sharing that with our staff. Huge advocate of cardiac rehab, and you know, just again, kind of level setting the why we're doing this. I know when it gets hard and other competing priorities come into place, which we'll talk about, you know, again, this is why we do this. So thank you for listening. I know some of you couldn't hear, and when we send the slides out, you should be able to watch the video at that time from your computer if it has audio through the computer. Okay, so we're going to go through in the next few slides, the team and who should be part of that team and who would best lead that team. And then we'll go into developing kind of your action plan. So I saw your answers on the survey, and I think there were 5 of you who were pretty neutral about this. And so the truth is, some of you may have been voluntold into this position, but I think it's really important to think about who that cardiac rehab champion is, and who's going to be the one who's the cheerleader and pushing when you get pushback from your CEO or others who are saying that, you know, maybe this isn't the best thing to invest in at this time. So I know that we have a second bullet point as passion and interest in improving cardiac rehab as a key skill set for your champion, but I'd actually probably raise that up to the number 1, right? Is you have to have that passion and the interest as well as the understanding of cardiac rehab programs. I will tell you, when I took over as champion, I for sure had the passion and the interest. I did not have the knowledge. I spent a lot of time trying to understand the billing and the coding and the finance piece, and we'll talk about that. And when you're building your team, if you don't feel like you have that piece, like who you can lean on. That champion should be credible and influential with peers, action-oriented, right, willing to push through and get things done, experience with change management and improvement projects, and great communication skills. So again, some of you may be here representing your hospital, and you may look at yourself and say, I may not be the best champion, but you're willing to help with the team. So, and a lot of us have seen changes in the last year with our staffing, with program support. I know several programs that have closed and are just starting to reopen, and people have retired or moved on to different positions because they weren't getting hours. So this may be a bit different for you, and you may have had that champion and maybe now looking for somebody new. So these are things to think about, as well as on the next slide. Again, it's the ability for that champion to engage and collaborate with hospital leadership and obtain support. So like Zena mentioned, your CEO is not so sure. It sounds like you obviously convinced them, him or her, so hopefully they will then continue to be your executive sponsor. I think also, we're going to talk about building the team, is having the patient's needs, the staff needs, as well as the business needs in mind. So that takes a special person to be able to bring all those together when advocating for a program. Conflicting interests, competing priorities. Right now, with healthcare and budgets probably tighter than they've ever been in most healthcare systems, is how do you take advantage of what you have now? How do you leverage your foundation, other grateful patients who might be able to support things that you want to do, but also understanding that energy may not be able to be put into, you know, what your program needs at this time. There was a question from Stacy around getting data, and you may not have a data analyst or an ethics specialist or an informaticist right now who's able to provide you with really granular data. So we'll talk a little bit about ways to change your approach to data when we get to that slide as well. So continue to support a culture of change. You know, people will look at you every time you come in the room and ask you what you're going to change next, and that's just part of it. And kind of be that cheerleader to make sure they know it's, again, for the good. And we'll talk about an aim statement and bringing back to the why in that important piece. And then we'll talk about developing the aim statement and action plan, and that person has to be comfortable in doing that, or finding a teammate who can really help them with that. Next slide. All right, so again, we reviewed this last year as well. Who should be on your team? And the next couple of slides go into a little bit more specifics, but who needs to be involved? And really making sure that you're thinking of the entire continuum from identification of patients, both inpatient and outpatient, as well as who can help with that referral and the enrollment piece and the participation process. So it's going to be different people. And again, the next couple of slides will cover that. Something important to think about as well is, like at our hospital, we have our hospital, and then we have our cardiac rehab program here. But we have a lot of patients who come here who don't live here. So we have developed really strong connections with the individuals in other programs, whether it's in our hospital system or outside of our hospital system, who may take different insurances locally for us. So we've really tried to make sure we have people giving input from other cardiac rehab programs. So it may not just be like your one outpatient program that you're thinking of. So trying to involve members from both. For sure, the inpatient, right? We know that's the best place to capture them. You have that captive audience. Zena, back to your question. I have learned more about billing and insurance and how that works, both from our billing and insurance personnel, but also from AACVPR. I really rely on those experts within that organization to help, and hopefully we'll bring some of that to you in our future modules. And again, you saw Stephen talk, but getting those staff and patient involvement, so it's not either top down from you, but also what do the patients want and what does that patient experience look like? So it's really important things to think of as you're building your team. So next slide. We talked about the cardiac rehab champion, whether that's you or someone else within your organization. Can't, underemphasize the importance of cardiac care clinicians. So really your cardiologists, your surgeons, and either some of the advanced practice clinicians, so physicians or assistants or nurse practitioners who are making the referrals, because without the referrals, you won't have a program. And so really making sure you bring a representative on, whether it's your medical director or not. It may be somebody else actually and not your medical director. And making sure you ask them questions about what works well for them and what are their barriers or pain points for that process. Obviously, you're going to involve any of your cardiac rehab clinicians, who whatever skill mix or different group you have, they're going to have a lot of great insight because they're the ones at the, in the program doing the work. A cardiac care manager, that could either be a manager for your program, or it can be a case manager on the inpatient side who's working with those cardiac patients. Some people have navigators or those types of managers. So that is the title of cardiac care manager, but it's someone who can really help with workflows and where your system may be dropping the ball. IT staff, super helpful. Again, back to how do we get data? Your program and hospital may have a nurse informaticist. It may have a data analytics team. It may have none of those, in which case, how can you it's just kind of, you may have to like seek around and kind of ask for who might be the best person to help within kind of your Epic. You might have an Epic order expert who can help with getting automatic referrals into order sets. So we have a cardiologist who's kind of our Epic lead. We definitely rely on him heavily. Or it may be even whatever system you are using for monitoring, they may have tips or tricks around how to get data and information as well. So it can come in different shapes and sizes, but definitely an important part of your team. Quality improvement leaders, if we talked about that being an important part of the champion, if that's not your strength, and on that very first slide, we had the kind of that circle of plan, do, study, act. If that's not your thing, just at least get a partner or somebody on your team who really likes that piece, because it's going to be really important as we talk about filling out your action plan. You know, somebody who we've added to our team kind of on an ad hoc basis this past year has actually been our infection control team. So that's been something really new for us to incorporate around spacing and safety and requirements. So they've actually been an informal team member as well, just something to think about. And then, of course, the patients, providing that end user perspective, always really valuable. We do a lot of rounds and ask very specific questions about the process, both during the program as well as on their exit survey. So now we'll talk about the model for improvement. And we did, again, go over this over a year ago, a long time ago, and some of you are new. So this is based on the Institute for Healthcare Improvement model for improvement. And there's other programs which are similar. You know, you have something called OKRs, or objectives and key results, and this is pretty similar to that. But really it's the what are we trying to accomplish? How will we know that a change is an improvement? And then the third circle, that orange circle on the right there, is what change can we make that will result in improvement? So we already filled out that circle for you, and that's the automatic referral with having effective care coordination in place. So now we're going to talk about kind of the yellow circle and the gray circle, which are going to move you to having success and getting to that automatic referral place. All right, so it's trying to keep it really simple. And sometimes I have the tendency to make things way more complex. So, you know, when you go and teach something that you always remind yourself of all the things you're not doing well. So this has been really good for me to review these slides again and come back to this, because I tend to make it complex. But I think the simpler you can make it, the better. So developing a name statement, we'll talk about that, as well as element 2, which is really around the data and how to assess or measure your progress. And then number 3 is what are those initiatives or tasks that you're going to do to then move element 2, which is then going to move element 1. So element 1 is your overarching goal. 2 is the data to show that you're getting there. They're called sometimes leading metrics. And then element 3 is really like, what are the specific things that you have to do in order to accomplish 2 and then ultimately 1. All right, so the aim statement. This could even be something that you call your own department mission, your mission or your vision, you know, specific to this piece, which is really around the automatic referral piece. But it's really good if you're doing teamwork and people are feeling like there's limited resources, limited capacity, limited time, to have a why and to have it posted. And this has not always been my strength, I have found out. I have a person I work with who's really, really good at this, and she's very good about reminding me, like, we got to go back to the why because you're getting pretty abstract. So creating the aim statement helps provide that beacon. And it provides the why behind what we're trying to do. Like, what are we really trying to accomplish? And the important thing to remember is this should be developed with your team. Again, I know it's hard to pull everybody together, to stop your operations, to cancel classes, to have a team meeting. But if you invest in this in the beginning, the return on that investment will be significant, and you'll be able to go back to the why and say, this is why we're doing it. Oftentimes people tie it back, like we tie our aim back, try to tie it back up to our mission statement for our organization as well. So maybe starting with your mission and vision for your organization, and then that can sometimes help as well as you're developing some of these statements. So again, the questions you need to ask is, what do you hope to accomplish? Again, we've talked about this, and that's all kind of the reason behind the cardiac rehab change package is increase cardiac rehab referrals, which ultimately should increase enrollment as well as participation. And this is really for those patients with eligible diagnoses because we know that cardiac rehab saves lives and reduces hospital readmission. So it really does reduce costs. And what that change is going to be that we're going to talk about specifically and really help you try to accomplish is that automatic referral with effective care coordination. So what we're taking is a really much bigger goal and helping you kind of make it smaller. So right, that question of how do you eat an elephant, and it's one bite at a time. So we're giving you a few bites of how to eat that elephant. For those of you who don't know SMART goals, this may be something new. I bet most of you, being in the field of adult behavior change, know SMART goals. And so SMART goals are great for your personal, professional, business strategies as well. So SMART is an acronym. And when developing these goals, it really helps to get as specific as possible. So what is the outcome that you want to achieve? And on the next slide, we'll show an example. Measurable, how is it going to be measured? Actually, go back one slide, sorry. I was just saying that we'll show an example on the next slide. And we'll get into this piece about data as well. Achievable, right? So we want it to be a bit of a stretch goal, but we don't want you to go from 1% to 100% because sometimes when you set too lofty of goals, there's actually some, kind of proven psychological barriers that go up if it's such a stretch goal that you don't think it's realistic. Is it relevant? So needing to link it back to the aim statement and time bound by giving yourself dates. I don't know if you operate this way, but I know if I give myself a timeline or a deadline, anybody I work with, I say, just give me a deadline. I'll get it done by then, but that helps motivate. And then it just keeps your team on track. So on the next slide has the TAKEheart aim statement example. So this is not one that you need to use, but please feel free to use it at the same time and just substitute whatever you may want to put in here. But again, so it's specific, it's telling the who. So the who is the MI, PCI, and CABG patients. And we're trying to increase those patients enrolled in participation. So kind of, again, back to what we're trying to accomplish. And then why is it important? Because it helps save lives and reduce readmissions. And then the time frame is in there. So we want to implement automatic referral by March 31st, but we know that we won't see a change in rates until maybe 9 months later. So giving yourself some time. The only thing I may add to some of these SMART goals is I like to see where my baseline is, so I know that number. So let's say we could use 100 as just an example. Like if we started off at 100 and we wanted to increase it by 30%, that's 30 patients. Right, so it's helpful in, when clinicians talk about the number needed to treat, or you try to want to talk about how many patients that is, you can break that down into months or weeks and how many that is, and that may be a more tangible number to your team when you start to talk about what you're really looking to do. Okay, so data has 4 letters in it. It's maybe not one of the traditional 4-letter words, but I know it can be daunting and hard, especially if you do live in a world of Epic. I have to remind myself that Epic was built as a billing system and not necessarily built to pull data. So there are certain data metrics which you can track on your own that are much easier. And so, there's also more metrics out there, and there's a lot more being incorporated into quality performance programs. So if good to do a survey, Steve mentioned, and he just put in the chat, if you don't know your baseline rates, it's fine to adjust your goal, and that's fine too. Is you may just, if you don't have your data, start tracking your data. And we'll talk a little bit about what data you can track. That might be a bit easier than depending on whatever electronic health record you're trying to get, especially when you start talking about rates and you need a numerator and a denominator. But I think it's really important. Data is just very powerful. And anytime you're going to go to a CEO or a CFO or an admin team, they're going to want data, and you're going to need to put it together. And it may be pretty simple, basic data, but as long as you're showing trends and changes and it's related to the interventions that you're doing, it's extremely powerful. It's really important today as we've moved into a value-based purchasing world as well. So again, how do you assess your progress? Have short-term and long-term goals and really make them specific with process measures and that are measurable. So we'll go into the next slide to speak a little bit more about this. So here are some examples you could use. The first one is a little bit harder to grab because it's the percentage of eligible patients referred to cardiac rehab will increase by 10% from first quarter to third quarter. Eligible patients is hard because it's a rate. So you have to know the number referred compared to the number who are eligible, and that's hard to get your data. And that was a question in the chat box. So you could just say, we're just going to increase the sheer number of referrals to cardiac rehab. And that's just a tally system where you could say, in this quarter or this month, we had this many referrals come in, and we want to increase that by 10%. And again, like Steve said, if you don't have your data yet, you can start tracking now. And that's just a tally that comes into your team. You can then look at the percentage of referred patients who enroll in a cardiac rehab program. And this one was saying increased by 5% from Q1 to Q2. The other thing you could just do is just the sheer number of patients in your program, because that should be then an increase of just be an increase in total number of patients. Again, that could just be a tally, like the number of patients you have in and then comparing it to later. So there are ways to simplify it with still having the data be really powerful. And then the percentage of enrolled patients who complete the cardiac rehab program will increase by 15%. Another powerful number which you can track now and then get some baseline data and start to track later. But these are SMART goals, and you can always put in your baseline data once you get it. Okay, so you have these goals, and on the next slide, don't go there yet, I'll show you a little bit more about what's being given to you if you haven't seen this already. But this is the interventions, right? So we talked about your aim statement, what data are you going to track, and then these are the interventions that you need to do in order to get there. And as we go through all these modules in the TAKEheart program, will help you, you'll start to add tasks in because you'll learn more about, hey, what should I do as you talk to your partner hospital groups. But you'll have to get specific in this action plan. So now you can go to the next slide, where it's really important to make sure you spell out the task, who's going to lead it, because you don't want to leave a meeting and not know who's going to lead it. Develop a SMART goal around that task, and then you can put in the status, the finish date, or any comments. These tasks here, the red ones, are populated from the cardiac rehab change package. So they're already evidence-based interventions that can work. The one little switch you could make to this action plan template is you have your aim statement, and right underneath it, you could put the data metrics that you're trying to move as well, just to keep it all on one page. And then the tasks will continue to add on as you get closer to it, or you dig and you realize you need to go into another avenue of looking into data or talking to other partners. There's some great comments in the chat box. I won't read them all because we're already at 12:56. But this is the action plan template. You'll get one, you'll work on them with your partners and throughout the next modules. And again, here's a SMART goal for a task. So a start date, an end date, how frequency they're going to meet. So this team is going to meet every Tuesday, Thursday to define changes necessary for automatic referral and complete it by a certain time. Really important to give those specifics because otherwise it'll be the end of July and you'll wonder where time has gone. So there's 4 minutes left. I'll start looking at the chat box. I think Hisham's going to come back on and we can start answering some of your questions. I think Steve does point out some good things. Again, this is how do you eat the elephant and how do you take it all, like chunk it up so you can break it up. And we just kind of threw the whole elephant in front of you. So don't worry about mapping all the activities out. Your first goal may just be like, who do I need to be on my team? Who do I need to talk to? And you could put your own task in there of develop the team by a certain time and make it a SMART goal. And you could start your own and that will allow you to at least kind of get started on that piece.
Absolutely, Kim. I think that this is very important. Adjusting your goals and actually building your team is very important. And as someone was saying in the chat box, is how do you get your EPIC report, for example? And so having an IS specialist that's familiar with EPIC that will help you generate those reports is going to be a critical piece. It may not be the most urgent piece or the first piece that you'd need, but it's certainly someone that you would need to have on your team.
All right, thank you very much, Hisham and Kim, for a lot of great content. You've positioned all of us to get off to a good start in this. If you have additional questions that you weren't able to ask, put them into the chat or make a note of it and address it in your peer action group meeting coming up next week. We want those smaller groups to be an opportunity where you can ask whatever you're wondering about, and we'll be prepared to support those questions. So just looking ahead to what's coming up next, we want you to continue working with your team to write your aim statement. You may need to tweak it later, but get a good initial aim statement started, and then think about the initial tasks that you need to get going on. And then be ready to participate in your peer action group next week. That's an opportunity you have to discuss your challenges and ask your peers how they're doing and get their input on things that you're struggling with. So those are the things to look forward to. And then the next module, module 3, that activity is coming up on June 24th, same time, Thursday afternoon from 3 to 4. The link is here. We encourage you to be there. And one thing I'd encourage you to do is different modules may be really relevant for some specific team members that you have. So if there are a couple key people for workflow processes, try to get them to listen in on this module. For automatic referral, you might want to get some of your IT people involved in that. So spread these registration links to the people on your team that you think would benefit from participating, because we want you to understand how your processes are currently working before you attempt to improve them. So thanks very much. We're right at 4 o'clock. As you close down your window, you'll get prompted to answer 5 feedback questions, and we really welcome and value your input on those things. So if you can take us just a second and answer those questions, we'd really appreciate it. Thanks again to Hisham and Kim for their overview today. Thanks to all of you for joining us, and we look forward to connecting with you again next week in your peer action groups, and then meeting with all of you in a month to discuss workflow processes. Thanks very much, and have an excellent rest of your afternoon.